Okay, thank you very much. I'm glad to see so many familiar faces and great to see some new people as well too. So I'm just going to give a little bit of a sort of setting the stage type thing for the evening. I'm really excited about the evening. The group has done a lot of hard work and there's going to be a lot of interesting presentations, a lot of really great opportunity for discussion and interaction and that kind of thing. So I'm very excited about that. Is there a bit of feedback? Is it okay? Just first of all, how many people here were at the talk in November, the first in this series? Were there many people here? There's a few people here. Okay, I'll apologize in advance. There's a couple slides that are repeated, but I think they're sort of important concepts and not too many people. So I'll go over those a little bit quickly. And so for everyone who knows me a little bit, I always try and squeeze too many things in. So I'm scheduled for 15 minutes. Hopefully I won't go more than 16 or 17. But so basically what we're going to try and go over in the next 15 or so minutes, the concerns with adolescent substance use. Why are we here? Why do we care about this? A very brief review of some neurobiology of adolescents. Brain development, which sort of sheds a lot of light on sort of why things happen the way they do. And we'll talk just very briefly about this concept of SBIRT, screening, brief intervention, or referral to treatment, which we're going to expand upon a fair bit sort of throughout the rest of the evening. So the reality is adolescents use substances, and we know that. And as much as we try and pretend that they don't, that isn't the case. And so this is just a little bit of data, and I apologize that I don't think this slide, the data made it into the handout. So there's a couple slides that aren't in the handout. But so this is from the BC Adolescent Health Survey, which happens every 5 years, most recently in 2013. And it actually shows the number of adolescents grades 7 to 12 who have ever tried either alcohol, the top line, marijuana, the middle line, or tobacco, the bottom line, is actually slowly decreasing a little bit, 2003, 2008, 2013 there. So, you know, that's a positive thing, but we still have very high rates of substance use, of adolescents trying substances, and so 50% of sort of grade 7 to 12 students have tried alcohol, and this is for the South Island, South Vancouver Island, and so that's a little bit higher than the provincial average of 45%. 29% have tried marijuana and 21% have tried tobacco. And so on the Saturday before the survey was given, they asked if you had drank any alcohol or used any marijuana, and 20% of South Vancouver Island youth drank. 20% of the 50% who had ever tried alcohol in the past before. So, and 2/3 of those were above the low-risk drinking guidelines. So 20% of 50% is so 10% of youth would have drank on the Saturday before, and 2/3 of those were drinking at excessive levels. So, you know, on a population level, that's going to be a lot of kids. 9% use marijuana, 6% used both. So this is just showing the age at which adolescents first tried alcohol. And so you can see 43% first tried alcohol at 13 or 14. And if you add up the numbers from 13, 14 and earlier, that equals up to 65% tried alcohol for the first time at 13 or 14 or younger. And so that's really important to think about the age at which people are starting to use substances, alcohol and other things. And we'll see in a couple slides why that's really critically important. 37% of those had 5 or more drinks on one occasion, so drinking above the low-risk drinking guidelines, so drinking a considerable amount. For marijuana, the bottom 20, again, 14 is sort of the age when people first start to use, if they're going to be using. And so for marijuana, 62% tried marijuana at 14 or younger. So over half of youth are trying marijuana at 14 years of age or younger. And again, we'll see why this is really important. So 23% used on 6 or more days in the last month. So a significant number of those are using very regularly, frequently, right? And so in the survey, they also asked about consequences of use, and 50% were sort of self-reporting that there was significant consequences of their substance use. So, you know, these numbers are not insignificant, and that's why sort of we're all here and looking at what we can do. Looking at some other substances most of the other substances are relatively low. Prescription pills without a doctor's prescription, 11%. This is a decrease actually from 2008, which is great. Inhalants also decreased a bit. All the rest of them were pretty much the same as 2008, not much change, sort of mostly in the single digits. So what's the big deal with alcohol or other substance use among teens? You know, lots of people say teens are gonna try things, right? That's just part of growing up. You know, kids are gonna try and get booze out of their parents' cabinet, or you know, get someone to buy it for them, or you know, use marijuana. What's the big deal? So I'll suggest that there's two main reasons that we're concerned. So reason number one is that adolescent substance use is significantly correlated with all kinds of harms. So you can read here: injuries, emergency room visits, school failure, violence, sexual assaults, other consequences of sexual relations, arrests, incarcerations. So all of these are dramatically increased, some more than others, with substance use. So when adolescents use substances, more bad things happen. In particular, driving is one thing that is concerning. This is data from OSDUS, the Ontario Student Drug Use Survey. They didn't have this kind of data really in the BC survey, so I used some Ontario data. And if you look at the top one, among drivers grade 10 to 12, only 4% are driving and drinking, right? So the message with driving and drinking is, you know, coming through relatively well. On the other hand, cannabis, on the right side on the top, 10% of drivers in grade 10 to 12 are using cannabis and don't feel like it's a problem. And so, you know, it'll be interesting to see what happens with marijuana legalization, you know, how that'll affect these numbers. But there's no doubt that, you know, cannabis use maybe is not as impairing in terms of driving ability, but it's definitely impairing, and accident rates are higher. And the reason this is important is because motor vehicle collisions at the bottom are the leading cause of death among young people, 16 to 25, and over half have a direct relation to alcohol or drugs. So, you know, one of the first things I always ask among youth, among everyone with any significant substance use, but especially among youth, is, do you ever drive or get in a car with someone else who has been using substances? So the second reason why it's really important is because earlier substance use leads to increased risk of substance use disorder. And this is why the sort of 14 or younger is really important to understand. And so this is a graph sort of illustrating that. Blue bars are for alcohol, red bars are for marijuana, and it correlates, shows the relationship between the age when someone began drinking or smoking along the x-axis, the bottom, and the percentage chance of lifetime diagnosis of alcohol or marijuana dependency. So in the blue bars, you can see if someone starts drinking it to a significant amount at 13 or younger, they have about a 50% chance of going on to have a significant alcohol use disorder. And for every year that we can delay significant alcohol use, we decrease their chance roughly 5%, right? So if we can delay drinking from 14 to 15, or 15 to 16, we're going to significantly, on a population level, decrease the amounts of alcohol use disorder that we have in our population going down the roads, right? That's one of the reasons that doing work with youth is so critical, because they have their whole lives ahead of them, right? And, you know, obviously I don't need to tell you guys that, but it's important to be reminded of that kind of thing sometimes. The curve is similar for marijuana, not quite as dramatic, but similar. So this kind of brings up a couple questions. Number one, why is it so dramatic, the age that people start using? And the second question is what we can do about it. And that's what we're going to discuss throughout the evening tonight, what we can do about it. And so let's just talk a little bit about why this is. So we'll talk just a little bit about the neurobiology of addiction, and then a bit about adolescent neurobiology. So this is a slide that I showed at the last talk as well, but I think it's really important, and it gets to what we understand about brain changes with substance use, specifically significant substance use. So Nora Valkow is the director of NIDA, the National Institute of Drug Abuse, and one of the reasons she's in that very important position is because of some of the seminal work that she did using imaging, fMRI, and CT scans, showing changes, neuroanatomical and functional brain changes that occur as a result of drug use, and that often lead to further drug use. So this is showing brains of people who, with cocaine, methamphetamine, alcohol, or heroin, and control brains versus addicted brains. And so, you know, someone who has a significant history of cocaine use, if you put them in a CT scanner, and they're not using cocaine right now, they just have a history of it. You put them in a CT scanner, an fMRI scanner, and you show them a picture of cocaine versus showing someone else who doesn't have that history a picture of cocaine, and their brain reaction is different, is completely different. And this just goes to show that people's brains are changed by addiction, and this is really important to understand that in terms of understanding why and how people suffer with addiction and what the needs are in terms of recovery. So now if we take a look at adolescent neurobiology, we're understanding also relatively recently that adolescents' brains develop much later, actually, many parts of their brains than we previously understood. So our physical bodies develop when we're 13, 14, 15 kind of thing. You know, we're physically mature, able to reproduce, have essentially adult bodies by the time we're 14, 15, 16 kind of thing. But we're understanding that our brains really are still developing a lot into our late teens for sure, and definitely, and even probably into our early 20s. And so having our brains be significantly exposed to substances during that critical developmental phase has effects on the way they develop, and generally negative effects on the maturation process, right? And so in addition to that, different parts of our brains develop differently. Right? So our limbic system, which is responsible for emotion, sensation seeking, that's sort of deeper parts of our brains that are phylogenetically older, develop earlier, so more in our mid-teens, versus more frontal cortex, which is involved with risk analysis, executive function, develop later. So, you know, teens, it's kind of like, the analogy is kind of like a car with a gas without the brake, right? We all know teens are, you know, often very interested in sensation seeking, risk taking sort of in their teens, but they don't kind of have the decision making and risk analysis sort of part figured out yet often. And so with teens who are starting to use a lot of substances in their mid to late teens, that can significantly retard that executive function development and have lifelong consequences potentially, right, on that executive function development. And that's, you know, at least a big part of the reason that we see this increase in substance use disorders long-term for people who have started using substances early on. So all of this sort of leads to really viewing addiction as a pediatric disease. You know, that's a really useful way of seeing it because the earlier substance use starts, the greater the chance that you'll go on to have substance use disorder. Almost all of addiction originates with substance use before 21. It's very uncommon that someone had no substance use, you know, earlier on and then develops, you know, significant substance use disorder. I mean, it happens, but it's very uncommon. Greater than 50% of all substance use disorders themselves actually having a disorder started before the age of 21. And as we know, adolescents are more likely to engage in risky behavior, and they do experience greater harm with equivalent amounts of substance use as adults would have. So we're going to talk briefly about what we can do about it. So I'll just give you a little bit of a very brief sort of framework of what SBIRT is, and we'll be talking a bit more about that, or parts of that, throughout this evening. So in terms of screening, I'm going to go by this pretty quickly, but the idea of should we be screening, if we do, who to screen as family doctors, as other healthcare professionals is, you know, a controversial question. As family doctors, we're always having everyone say, you should be screening for this, you should be screening for this, for this, for this, right? And, you know, obviously every, you know, practice is going to do what they can do and what they feel is realistic. You know, I would encourage some form of screening whenever there's an interaction with youth. Different organizations have different perspectives. The AAP, American Academy of Pediatrics, the Canadian Pediatric Society, both sort of recommend doing regular screening. The United States Preventative Service Task Force says there's insufficient evidence to recommend screening for adolescent substance use, but there is for screening for tobacco use. Tobacco use is associated with other substance use, so you can make of that what you will. The College of Family Physicians and the Canadian Task Force on Preventative Healthcare have no guidance on the subject. So what age to start screening? So basically, when a child is old enough to be interviewed on their own is a good time to start considering it. Most sort of experts are looking at the 11 to 13 range, right? Before you start really getting that significant increase of kids trying at 13, 14 kind of years old. The NIAAA, National Institute of Alcohol and Alcohol Abuse, in the United States recommends 9 to begin asking about alcohol. And in younger kids, we often use a less threatening way of asking about friends. So have any of your friends ever tried any alcohol? Is anyone sort of around you using alcohol? And that's a really strong predictor of going on to use alcohol yourself if friends are, because a lot of people won't say about themselves, especially younger kids. So basically the point is it's younger than you think. So a question of how to screen, and so there's good evidence, and I'm not showing it here just in the interest of time, but clinical judgment alone is not very good at picking up substance use. And so the bottom line is using a tool, a validated tool, and we'll talk more about the craft. I think it's probably in the handout. There's a number of other ones as well too. I did a little search on the University of Washington's substance use screening and assessment database and came up with 233 records for adolescent substance use screening tools. So there's lots out there. Most obviously aren't used that much. But one that I would like to just introduce you to, and if you're interested in, I can give you more information about it, is one called the Screen to Brief Intervention, S2BI it's called. And so this is a paper published just about a year and a half ago by a group out of Boston Children's Hospital, Sharon Levy. I was fortunate enough to go down and do a little bit of work with them and sort of saw their approach. And so when she was developing this in her group, the key was having something that would accurately discriminate between risk categories and be really fast. And so basically they distilled it down to essentially a one-question screener, which is what this is, asking about each of the different substances. So ask basically one question with multiple parts, asking about tobacco, alcohol, marijuana, other illegal drugs. And the response items on the far right are in frequency. So never, once or twice, monthly, weekly, daily. And so down on the bottom here, if a person answers no, if on the screen to brief intervention, if they answer once or twice of the use, then they probably don't have a substance use disorder. If they answered monthly use, they probably have a mild or moderate, and if weekly or greater, they probably have a severe substance use disorder. So this is potentially a way that this can be integrated into workflow that's quick. And she actually, in her studies, it was all youth in waiting rooms filling this out on an iPad, and it took on an average 32 seconds for them to complete it. So, obviously technology can be a barrier to that, but, as we're moving more and more to electronic means, it may be an option for some people. So brief intervention, I'm not going to go into this at all. We'll be talking about it a lot during the session, but just to show a couple of, these are 2 meta-analyses, many patients, almost 2,000 patients, effectiveness of early interventions on substance-using adolescents. So basically, value of early interventions for targeting adolescent substance use has a positive impact on reducing substance use and other behavioral outcomes. Another meta-analytic review, similar 5,000 patients, saying MI, motivational interviewing, is an effective intervention for promoting adolescent substance use behavior change. So there's good evidence for doing this. Referral to treatment, basically anyone with moderate to severe substance use will need to be referred on. And that's one of the points of this evening, is to meet a whole bunch of sort of referral sources or referral sort of options for family docs out there. So what can we do about it? We're going to find out about it now over the next few hours. Summary: adolescents use substances. Early substance use increases morbidity and mortality. The earlier you initiate, the more likely you'll go on to have a substance use disorder, largely because of neurobiological factors. And I would propose that we should at least be considering screening, intervening, and then referring when appropriate. So I'm not sure how much I went over, hopefully not too much. But please feel free to send me an email with any questions. I don't think we'll have questions right now because we'll probably need to get going, but any questions sort of throughout the evening, please feel free to ask me. Great.